morning. This is the session Addictology, and I think we can regard this session as in one element, it's a continuation of the wonderful talk of even Montoya, but actually moving from plans in phase 1 and preclinical study to reality, and talking about long-acting opiate agonist treatment. So it's really a new reality that we're facing, and so it's very interesting to hear this. On the other hand, I think it's a great contribution to the late Mary Jane Quick. I think she always had a very ambivalent relationship to new things new compared to methadone. I once heard her expressing that the heroin-assisted treatment, she said the only place where they do it well is in the Netherlands because they also give methadone. And so I basically think about heroin-assisted treatment as a heroin-assisted methadone maintenance treatment. So I think she would have mixed feelings about these developments from buprenorphine and now from buprenorphine to these long-acting medications. But at the same time, I'm sure that she also believed in progress and to find the best ways for her patients. So it's with that in mind that I would like to open this session. So it's really a tribute and a continuation of what is currently going in the United States with new developments. Here we're talking about new developments that are in place or will be soon in place, and we have some excellent speakers this morning. They will have 15-20 minutes for their talks, and then after that we will have an overall discussion because the talks are very close to each other. They give a lot of details, and so we can discuss it in one go. So let's start with the first presentation. The first presentation is by Frank Gray. He is the head of the International Medicine Development of Indivior. He is located in London, and he's talking about Sublocade, long-acting buprenorphine, from the clinic into the real world. Frank?
Thank you, Wim, and thank you for the invitation to speak at the meeting. Really appreciate it, especially in such beautiful surroundings. My talk will start, most of it is new data, a little bit of previous data you might have seen, and a lot of the data I'll be presenting is about to be published or in final data. Just to say, as my conflict of interest, all the studies were funded by Indivior, some were sponsored by Indivior, and I'm an employee of Indivior. So just the introduction to introduce you to Sublocade. It's a once-a-month long-acting subcutaneous buprenorphine formulation. It is approved in many regions, but I want to make it clear it is not yet approved in France. Sublocade is dosed in most patients after they've been on a transmucosal period of transmucosal buprenorphine and then 2 300 milligram doses followed by 100 milligrams. That dosing regimen gets us to therapeutic doses from the start, and we've done some studies to show that that blocks the positive subjective effect of opioids, and some patients that need higher buprenorphine concentrations may be maintained at the 300 milligram dose. And then Sublocade should be part of a complete treatment plan that includes counseling, psychosocial interventions to help with deconditioning of patients. So I'm going to start with some of our long-term data. The first part would be an integrated data from our phase 3 development program, which shows data up to 18 months. And then we'll look at what happened to our patients after they left our development program in the RECOVER study. This is just an overview of our phase 3 development program. The first study was a double-blind randomized study where we randomized patients to 2 doses of Sublocade, a 300 maintenance, a 100 maintenance, and placebo. Patients that finished that study could then start the next study for another 6 months, and these are the patients we call the rollover, so they went from the first study into the second study. We also had patients that started specifically in that study, which we've called on the slide the de novo patients. So once all the patients had 12 months of treatment, they could roll into an open label extension for another 6 months of treatment. And what I'll be sharing with you is the combined analysis from the 18 months worth of data. So first, just to start with the efficacy results, what you can see on this slide is an observed analysis of patients that remained on treatment and what happened to their abstinence. And what you can appreciate over time, you have an increased rate of abstinence up to the 18-month time point. As you can see in the box, the likelihood of being abstinent in our analysis increased by 12% for every 6 months that patients were retained in treatment. I also want to share the safety data. So for patients that were retained in treatment, these are the proportion of patients that were experiencing adverse events. And you can see at the start of treatment, we have the adverse events, and that gradually decreases over time as patients are retained in treatment. So patients being retained in treatment, having an increased abstinence and a decreased burden of side effects. Now to move on to the RECOVER study, which I don't have lots of appreciation for. So the RECOVER study was really a way we wanted to find out what was happening to our patients after they finished our clinical trial program. So in a more controlled environment, moving into more of the sort of real world and interacting normal. So the pool for patients were from the 844 patients that completed our phase 3 program. We had 500 of those patients included in the RECOVER program, and we followed them for a period of 2 years. And we've recently just had data on an extension of that through the Virginia Commonwealth University, or VCU, where they've looked at the same cohort 2 years after their last RECOVER assessment. So we now have data on this cohort for up to 4 years. Just to orientate again, patients could enter the RECOVER study after they finished the 12 months of treatment. So there were some patients in the RECOVER study that were also in the extension study. So the data I'll be showing you on the next slide will be the 18-month data for everybody after their last treatment of Sublocade, so the 18 months after they exited the treatment program. And the type of analysis we had was looking at their substance use, their lifestyle, quality of life, health initiatives, and also some social measures. So a few years ago, we presented at ATHS the 12-month data, and we see similar trends in the 24 months data. So the first to say is, in the full cohort, 18 months after they came out of the study, just over 46% of patients were still abstinent or self-reported no use of opioids for that full 18 months. The data in the line graph is showing you at each assessment, patients were self-reporting their previous 30 days of opioid use, and you can see 64 to 72% of patients at each visit were free of opioids in that analysis. We further wanted to look, which is the analysis on the right, what was happening to patients who had longer periods of treatment duration. And what you can appreciate from the bar graphs is the patients with the longest treatment duration had the highest reports of sustained abstinence for the full 18 months. So for patients that have been treated up to 18 months later, 62.5% of them reported abstinence for the entire period. And that was 52% for those that were treated for 12 months, and those that were treated more than 6 months, 47%, which we thought was really interesting, showing this duration of treatment along with the psychosocial care, and maybe start sticking to things like behavioral or changes in conditioning. I just want to touch on the RECOVER study. This is 4.2 years after the last RECOVER assessment, but roughly 2 years after they left the RECOVER study. We had just over 200 patients, 216 that contributed data. As you can see in that period, since their last RECOVER assessment, there were 45% of patients that had used opioid in that period, meaning 55% had not. And you can see the most common opioid there was heroin, but we're also starting to see more polysubstance abuse, the emergence of fentanyl use, and you can see some patients were still in therapy, or either on methadone or on buprenorphine. The interesting bit with this particular cohort is we also had the opportunity to sort of review the impact of COVID-19 on their recovery assessments. So part of this, we had a specific question on their recovery, and if COVID made their recovery more difficult, and 26% of patients did say that. And it's just interesting, in that 26% of patients, they were the patients more likely to be using opioids in the recovery period. And also interesting, when we looked at what factors might be driving that, We saw patients with higher scores, depression scores, recent substance use or in treatment were more likely to say that they felt the COVID sort of situation was making the recovery more difficult. Just to say, this is the tip of the iceberg with this data, and there'll be more data coming out. We're actually analyzing this, and there'll be more publications. So I hope you appreciate what we are showing is with longer-term treatment, we're getting better abstinence use, and also those patients are having less side effects. And also an interesting cohort in the recover cohort showing what happens to patients after they've left, and seeming to show that patients that were engaged in treatment longer were getting better outcomes, and also some effects of COVID on that. So I want to move from that just to focus on some of what we're calling high-risk populations. And those are patients using fentanyl, and or those that are injecting opioid users. So you may be aware there's much more fentanyl coming into the distribution chain, specifically in North America. Lots of the overdoses are now driven by patients that are overdosing on fentanyl, and that's driving an increase in the death rate. We previously published some work where we gave intravenous infusions of buprenorphine to set plasma levels, showing that you needed to be at levels above 2 nanograms per mol, and that might decrease the respiratory effect of using fentanyl. We've done some more modeling on that and really shows us an interaction at the mu-opioid receptor. So when you have buprenorphine occupying the mu receptors, if someone uses fentanyl on top of that, that's reducing the amount of respiratory depression that they get. So we just pulled some interesting data from another study we did. The primary study we were doing was looking at initiating Sublocade after a single dose of 4 milligrams of transmucosal buprenorphine. The patients were monitored for withdrawal, treated with transmucosal buprenorphine, and if they had no precipitated withdrawal or adverse events from the buprenorphine, they could go on to be injected. The interesting thing in this population was that of the 26 patients we enrolled, 20 patients tested positive for fentanyl on their urine screens. More interesting was 5 patients of the 20 self-reported fentanyl use, which means the majority of patients being exposed to fentanyl were unaware of this. So we did a sort of a sub-analysis on that population just to see if we could expect in this population similar types of efficacy or safety data. You can see it's a typical population we would expect from opioid use patients. So specifically looking at efficacy, you can see on the table on the left, after the first injection after a month of treatment, we still got high levels of opioid use and fentanyl use, but from the second month on of treatment, we see a reduction in that use, which is very similar to the previous data I've shown you. Similar with the adverse events, the profile we are seeing shown on the table on the right is similar to what we've seen with buprenorphine products in the past, and also similar to what I showed before, where most of the adverse events were reported after the first injection and not after subsequent injections. Quickly moving to patients that are injecting opioids. And our interest in this came from a sub-analysis from our double-blind study. So just a quick reminder of that study. Patients were inducted on sublingual buprenorphine, randomized to the 2 doses of Sublocade or placebo. What we saw in this population was, So this is just data in that subpopulation of injecting opioid users. So while Sublocade worked in all patients, there was indications that those that were maintained on the 300 milligrams did better over time, both in retention and in opioid use. And that did map well with what we're seeing from a pharmacokinetic point of view, that those patients were the patients that were having higher levels of buprenorphine over time. So that moves us to a real-world study. I just wanted to sort of set that up. So we've done a real-world study in Canada, and I've got a little bit more data on the study in my subsequent files and real-world section. But this was a study in patients, 140 patients treated by 7 physicians across Canada. It was a retrospective chart review. One of the measures of interest was patients with overdose. Luckily, most of those overdoses were non-fatal, but could quite easily have been fatal. So what we can see from this is it's not only an indication that long-acting buprenorphine might have a sort of benefit on overdose rates, but specifically all the overdoses we saw in the study were in patients that were using opioid-injecting users. So just to summarize that, we looked at fentanyl patients just to show they get similar types of efficacy and safety as we would anticipate. So now maybe more interesting, some of the real-world data. So what I've shown you what we've seen in the clinic, what we see in real world and real practice. The first study we conducted in Australia, we sponsored this, but we funded this, but it was sponsored by NDOC in Australia, and it's their data analyses I'm sharing. We recruited 100 patients from 7 sites in Australia. CoLab stands for Community Long-Acting Buprenorphine, and they were interested to see if there were differences in different treatment settings. Interesting data, what we saw in the real world is higher retention rates than we saw in the clinical trials, and those for you that have experience with the long-acting atypical antipsychotics, you may not be surprised by that, but you see 86% retention at 6 months and 75% at 12 months. More interesting is the forest plot. So what we see there is the odds per month of treatment of decreased or increased use. And you can see of all the sort of drugs of abuse, illicit drugs, except for cocaine, there was a reduction in use month on month. You can specifically appreciate the reductions in craving, heroin, other opioids, also to pull out the reduction in injecting use, and also just to show that those patients were 60% more likely for each month they were in treatment to be in employment. The next, once we advance, I can share the data from our Canadian study. So this is a little bit more on the patients I showed you before. It's an open-label, multi-cohort retrospective study, sort of doing chart reviews of patients with 6 months, and we included patients that had received any opioid agonist. So that included extended-release buprenorphine, sublingual or transmucosal buprenorphine, and methadone. You will appreciate from this table, more of the methadone patients had a longer-term opioid use history, as well as higher levels of injectable opioid use. And because of that, maybe not surprising, higher levels of HCV use. The actual history of prior reported overdose events was similar across the groups. And the patients in extended-release buprenorphine and methadone were more likely to have come from treatment. So there's a little bit more granular detail on that, looking at adherence or retention. So adherence being the patients having more than 5 months of treatment, with retention being them have been on the same treatment for 6 months. You can see good levels of adherence and retention for both methadone and long-acting buprenorphine. Less non-fatal overdoses in the long-acting buprenorphine group than methadone. The chart on the left showing you the retention rates. But interestingly is the pattern of overdoses that we were seeing in this particular cohort. So if you focus on the methadone cohort, again, you might not be surprised to see that a lot of those overdoses or patients with overdoses were on treatment initiation. But you can also appreciate as those patients stay in, they're still having overdoses in those first 6 months. Reduced number of overdoses in sublingual buprenorphine group, similar pattern, and then the one case for extended release buprenorphine. So just to conclude on that, we've got some interesting preliminary results on real-world data. I just wanted to say that the Australian cohort, we have shared the 12-month data. That cohort's ongoing, and we'll be getting 24 months data from that cohort later this year. And if I'm fortunate enough to be invited back, maybe I can share that next year. And also from our Canadian experience, showing a potential benefit, looking at the sort of baseline imbalances, we really need to run a validation cohort. And I just want to confirm that that study is ongoing, so we are looking at that validation cohort, a bigger cohort of patients that will be more balanced at baseline to see if that reduction in overdoses holds. And Wim will be happy to say I'm done. And I'll be happy to take questions afterwards.
Thank you, Dr. Gray. And now, next speaker, Thank you. Thank you, Professor. So my name is Freddy Thieberg, and I'm actually the head of Cameras, which is the company behind the development of Buvidal. So, of course, I'm conflicted, as you understand. But I am hoping this is a development we have been working with over 15 years. And of course, it covers a number of different studies. But here I will talk about the patient experience. So we have performed a study in Australia together with a large group of excellent clinicians where we looked at how the patients perceive this treatment. So that's the focus of my presentation. I'll try to be quick. But before I go to the next step, I must say it's great to be back in France. It's great to be relieved from all the whatever COVID things, and fantastic to be in Biarritz. So moving forward, I think, can we get the next? Oh, there we are. Just a quick introduction. So this is a different depot technology to what was presented in the previous call. It's a subcutaneous depot injection of buprenorphine. It's referred to as, trade name is Buvidal, and it's also referred as CAM2038. So this is a ready-to-use solution, basically in a small dose volume varying from 0.15 to 0.64 milliliters. So that is injected under the skin, and subcutaneously it can be injected into multiple sites, into the buttock, abdomen, upper arm, and thigh. Once injected, this is based on a lipid composition. So lipids is like cell membrane building stones, for instance. This is a combination of two different lipids, and once injected into the subcutaneous tissue, it comes in contact with aqueous media there. It immediately transforms into a liquid crystalline gel. So basically what happens is it goes from a liquid to something like a green pea under your skin. And then that depot is then slowly degraded over time. And the reason we developed this was we looked at how is buprenorphine used in the current clinical setting, and we tried to adopt that into all of those years of experience into this depot product. And to be able to have it as an individualized treatment, we developed two durations, one weekly and one monthly. And you can see here, this is population pharmacokinetics showing the daily PK profiles when you take sublingual buprenorphine versus the weekly, and then the monthly. And the absolute levels can then be varied by varying the concentration. So we have different concentrations of monthly or different strengths of monthly and weekly products. So that's the product that we will be discussing today. And I'm hoping this guy can help me. Is there somebody here that could? Oh, there we go. Of course, there is a lot of evidence behind this that we have produced through the clinical trials up to registration in Europe, Australia, and the UK at this point. We have demonstrated, as you can see in these articles, and I'm happy pleased to provide these to you if you're interested afterwards. We have shown effective suppression of withdrawal and cravings, and in several different studies and different types of populations. We have done a study of blockade of opioid effects, which demonstrated full blockade of opioid effects from the first weekly dose. In this case, it was 24 milligram, and that can be seen in this JAMA psychiatry paper. And then, of course, worked and presented pharmacokinetic backgrounds. In our pivotal study, we studied head-to-head against sublingual buprenorphine the opioid use in two populations. They were all new to treatment patients. And then they were treated over 6 months, and there we were able to demonstrate both non-inferior efficacy and superiority on the first secondary endpoint. Throughout studies, we have had high retention rates, and the safety profile has been comparable to buprenorphine and sublingual buprenorphine, except for mild to moderate injection site reactions. So now over to the topic of this presentation. So with our great clinicians, we conducted a study, it's called DEBUT, the Depot Evaluation Buprenorphine Utilization Trial. It was published this summer, so you can read it here, but the reason I have this here is just to acknowledge the authors here. Nicholas Lintzeris, Adrian Dunlop, Paul Haber, Dan Lubman, Robert Graham, Sarah Hutchinson, and others. And I think that's the main contributors, of course, to this paper, and then we also have some contributors from the company, Cameras, here. So the study design was a randomized multi-site active controlled trial of depot buprenorphine versus standard of care in Australia, which is then sublingual daily buprenorphine in this case. And I would say most patients there are using Suboxone film, so there was a high amount of Suboxone film treatment here. The primary endpoint was patient-reported, so the treatment satisfaction questionnaire for medication. It's a validated questionnaire, and the primary endpoint was the global satisfaction score. This tool is divided into 4 different domains, and then the secondary endpoints was treatment effectiveness, so reported by the patient, convenience, reported by the patients, and side effects. And in addition to that, we had multiple other patient-reported outcomes in terms of treatment burden, quality of life, opioid use behaviors, etc. And as you can see, we screened randomized patients that were currently on treatment with buprenorphine or alternatively new to treatment. Actually, the study ended up with only having patients switching from treatment of sublingual to weekly and monthly depot. So you can see they were randomized. The sublingual group were using flexible dosing up to 32 milligrams, so a little bit above the standard doses here in Europe. Of course, there are approved doses in Europe due to the Australian tradition in this regard and guidelines. And the weekly depot was administered once weekly, the monthly once monthly, and you had this dose range as you see on the slide here. So I'll try to move a little bit quicker. This population, we had 120 adults, 70 men, 49 women, 6 outpatient sites in Australia, intervention, 120 were randomized, 119 received treatment because 1 patient in the standard of care group dropped out before getting his first dose. Looking at the demographics, you can see them here. Average age is around 45 years, so relatively high. And you see the distribution between males and women. Very similar. There were more hepatitis medical history in the depot buprenorphine group, most likely because through the randomization there were more heroin users in the depot group than in the sublingual group. That was a chance happening. Cravings in these patients were relatively low as they were on treatment when they entered the study. See if I can get this one moving. I had missed one side there. So this just shows the rest of the demographics, the opioid use history, where you can see that there were more heroin users entering the study in the depot group. And you can also see there was a lot of concomitant drug use, amphetamine, cocaine, cannabis, etc. So then looking at the primary endpoint, which was then the pre-specified treatment TSQM global satisfaction score, you can see that there was a clear favoring of the depot treatment among the patients, which was statistical, of course, a p-value of 0.01. Yeah, the confidence intervals was well within that margin. So moving it over to a more maybe better presentation of the data, you can see the primary endpoint on the left-hand side, the global satisfaction score. So when the patient came in, the baseline value at week 0, they are fairly similar. And then you can see after week 12 and week 24, there is a significant treatment difference between the depot treatment and the sublingual daily medication. And this is also seen in the convenience score. We actually had the week 4 data, and the convenience data was statistical from week 4, whereas the effectiveness score, which is the perceived effectiveness by the patient, continued to increase up to week 24, and we don't have data after that, of course.
Stay to the microphone.
Okay, sorry. I'm very sorry about that. So that was the effectiveness score, and then we have the side effects. So that's the perceived side effects by the patient, and you can see that there is basically no difference. So side effects were the same in the view of the patient based on this protocol. So this was the primary readout, patient satisfaction. We also had a further patient satisfaction tool in the study, also was significant in terms of treatment difference. But then we looked at a few other interesting things, including the patient global impression of improvement, treatment burden, so the burden that was perceived by the patients, and the quality of life of the medication. And you can see that in all these cases, the depot treatment came out as positive. Treatment burden and also the opioid substitution treatment of quality of life, which there was only one subdomain that was statistically significant, but the other data also favored the depot treatment. Looking at study retention, you can see that there was high retention in both groups, so no difference. And I think it's worth noting that patients who passed the 24 weeks of treatment, they were offered, those that were in the sublingual group was offered to transfer over to the depot treatment. So that is, of course, confounding of the data in this case. But overall, high retention. And I think one important aspect here is also what kind of doses did these patients stand on? And you can see that here is a summary of the weekly and monthly doses that over the dose range that we were studying. And as you can see, patients really used different doses from the 8 milligram weekly dose. 8 milligram is, of course, a very low weekly dose compared to the standard dose of 60 milligram oral buprenorphine, but it still was sufficient in these patients to continue. They did not all of them did not dose escalate. And as you can see also in the monthly dose group, there was a variation between the 64 milligram dose and the 160 milligram dose. Overall, maybe Australia had a little bit higher doses than we see in other regions, but I think it's quite representative. And then I also touch upon another point is that there were some patients that received a supplementary dose. You could have an 8 milligram supplementary dose. But 20 patients out of 60, but 15 of those, so almost all of them, only received one single supplementary dose. And one client used 4 doses. So they were freely available in the study. Next slide, hopefully. So, safety tolerability consistent with sublingual buprenorphine. You can see that both groups had similar ones. What we did see, and of course it's natural because we were very eager to look at these data, is some injection site reactions, which were mainly mild and some moderate. So in conclusion, what we saw in this study, which was focused on patient-reported experiences, was that the study met the primary endpoint of the TSQM, so the Treatment Satisfaction Questionnaire for Medication, the validated questionnaire, for global satisfaction at the end of the study. It also showed significantly higher treatment satisfaction for effectiveness and convenience, with no difference in the safety domain. And we also, of course, showed improvements in the patient global impression of improvement, reduced treatment burden, and improved quality of life for patients. And we also saw some interesting signals in the opioid-related behaviors, so relating to aberrant use of opioids. As regards to the traditional opioid use outcomes, there were no surprises in the study. If you're looking at the illicit opioid use, for instance, there was very little in this population overall. So this is really focused on the patient experience. I think what is interesting here is to see how this learning about patient-reported outcomes can be used in treatment practice in the future. And with that said, I should move towards the end of the presentation. I do want to thank all the staff and clients that participated in this study, in the services, and you can see the names here. And again, a large thank you to our great clinicians and researchers, and also to the network of the New South Wales Alcohol Clinical Research and Improvement Network. With that said, Biarritz is great. I come from Malmö, so I had to take a picture and show it's a reasonable place as well. Thank you for listening.
Thank you, Dr. Thieberg.
Thank you, Frederick. We'll come back with questions at the end of the session. So now I call for Adrian Dunlap. I hope he will be there, from Australia. It's probably quite late there, so let's see whether it works. Adrian? Adrian? Oh, okay, look. Hi, Adrian.
Bonjour. Comment ça va?
Bonjour. Bonsoir.
Bonsoir, bonsoir.
Okay.
So
Thank you for being with us here in Biarritz. It's wonderful weather here, and we're having a great conference, and so we're very happy that you could join us from Australia. So you have about 15 to 20 minutes for your presentation, and we will have a discussion questions at the end of the session. So please start your presentation. We're most curious.
Sure. So can I check? You can see the presentation?
Not yet, but I see something is happening. Yeah, maybe, yes. You're going to the...
C'est bon?
We see it. It's wonderful. Thank you. It's your turn.
Okay, merci. So following on from Frederick's presentation, I'll talk to you about a study of buprenorphine, Buvidal, CAM 2038 in prisons in New South Wales in Australia. To start, I'd like to acknowledge the co-investigators, particularly Dr. Nick Linzeris and Jill Roberts. The study was funded by New South Wales Health, and Cameras provided buprenorphine for the study. Of course, opiate treatment is very important in prison and after release from prison, and in particular, it's important because there's a protective effect, a very strong protective effect on reduction in overdose of people who leave from prison if they're continued on opiate treatment. Unfortunately, in Australia, there's inadequate treatment in prison. There's not enough treatment in prison. The number of people in prison has grown 1/3 in New South Wales. but treatment has not grown alongside this increase in the people in prison. And so there's a under-response, a lack of response of not enough treatment occurring. So we were interested in looking at the safety of buprenorphine in prison. Now this may not make a lot of sense in France, but in Australia there's a very significant problem with diversion of Suboxone in prison. Suboxone is administered in a supervised setting in prisons in Australia, but there's still a big black market of illicit, non-prescribed Suboxone in prisons in Australia. In fact, it's the biggest drug, the most common drug that's used in prison, more than cocaine or methamphetamine or heroin or other drugs. It's the most commonly drug that's used non-medically. So we were interested in looking at what happens if buprenorphine was introduced in prisons. To be included in the study, patients had to have an opiate use disorder, and there were not very many exclusion criteria. Pregnancy was one, having a mental condition that meant that patients couldn't give consent was another. So it was a case control study. There was a control group of patients who were already on methadone, who were already stabilized on methadone. The patients that we offered buprenorphine were people with a history of opiate dependence, but they were not currently on treatment. So they were in prison, had opiate dependence in the history, but not currently receiving sublingual buprenorphine or any other treatment. And the study occurred in 7 prisons across New South Wales, a mix of different levels of security, low, medium, high security, and male prisons and female prisons. Methadone treatment was typically high-dose methadone, usually 80 milligrams or above. For the buprenorphine group, we gave them a single dose of sublingual buprenorphine, 4 milligrams to start, and then 4 weeks of weekly depot long-acting buprenorphine, and then 3 months of monthly depot buprenorphine. And the doses could be adjusted up and down by the clinician. The weekly doses and the monthly doses could be adjusted. So in the depot buprenorphine group, we assessed 80, 69 enrolled, and 59 people completed 16 weeks of treatment. In the methadone group, we assessed 79, 64 enrolled, and 60 completed 16 weeks of treatment. You can see the age, it's typical of people in prison in Australia, mostly men, very sadly, many Aboriginal people, common to not finish education, a higher prevalence of hepatitis C RNA positivity in the patients on the depot buprenorphine arm because they weren't in treatment when they commenced the study. In the findings, it was common for patients to report adverse events, but these were not severe adverse events. So there were only 2 serious adverse events of the patients on depot buprenorphine, and they were not related to the study medication. There were adverse events, but you can see they were mild adverse events. So things like injection site pain, constipation, swelling at the injection site, headache, redness at the injection site, but they were nearly all mild reports, not moderate and not severe. We looked at diversion of the medication, and there were no reports of diversion, attempts to divert depot buprenorphine. This was objective and subjective measures. there continued through the study to be reports of diversion of sublingual buprenorphine. We looked at costs, so costs to the prison system and costs to the healthcare system in prison of depot buprenorphine and methadone, and then we had a third comparison group of patients on sublingual. And you can see the costs in Australian dollars were $140 approximately for 1 month of treatment for depot buprenorphine, $360 for methadone, and nearly $1,500 for sublingual buprenorphine. And the main difference in the costs is for two reasons: the fact that depot buprenorphine is provided less frequently, and then the amount of staff time, both for health staff and for prison staff, is much less with depot compared to methadone, and it's much more with sublingual. The retention in treatment was high, it was above 80%. And the patients in the depot group who nearly universally reported using illicit buprenorphine, non-prescribed Suboxone at baseline, reduced this dramatically across the treatment period. At baseline, they were using about 28 days a month, and this decreased to 6 days per month at week 4 and week 16. We also looked at the same measure that Frederick's just talked to you about, the treatment satisfaction questionnaire for medication. And it was similar to methadone across the different measures, the global scale and the measure of convenience. However, the measure of convenience showed a benefit, a small benefit of depot buprenorphine over methadone. The health staff reported lots of reports of seeing this is very good, and you must understand that this is in the context of patients not previously being offered treatment. But also, interestingly, the prison staff also were very enthusiastic about this treatment and thought that it had a lot of advantages over methadone or sublingual buprenorphine. And it's unusual to see prison staff so enthusiastic about a medical treatment for addiction. So our study did not find problems with diversion of depot buprenorphine, even though we saw lots of adverse events. They were mild, retention was good, and drug use of patients not previously offered treatment decreased very rapidly once they'd started on depot buprenorphine. And the costs of depot buprenorphine were less than methadone and much less than sublingual buprenorphine. This study's just recently been published earlier this year in May in the journal Addiction. I should also remark on another important study of Sublocade that's just been published in JAMA Network Open by Joshua Lee. He looked at Sublocade being started in prison, but the effects on release. So that's also good to look at. It shows that retention is much better with depot than it is with sublingual buprenorphine. So, of course, around this time, COVID, or soon after this study was completed, COVID had an impact in Australia, and there was a potential very big problem with patients not being offered opiate treatment, being in prison, and prisons being environments where there's lots of concern about a lack of treatment and, of course, spread of COVID. Fortunately, our health department responded by providing more funding for depot buprenorphine treatment. And you can see that the changes in the number of people treated. So this is the number of people treated in prisons in New South Wales. The yellow line is sublingual buprenorphine, Suboxone. It nearly disappears early in the pandemic. The methadone is the blue line. It decreases by about half. And the grey line is depot buprenorphine, Buvidal. It increases from being very small at the start to being over 2/3 of treatment. So treatment expanded by about 1.5 times during this period, which is very good in a situation of under-treatment. And the group is also now interested in looking at what happens to patients after they're released from prison. Merci beaucoup pour votre attention.
Thank you very much, Adrian. I hope you can stay with us for a while so we have the discussion later on.
Sure.
Okay, let's move to the final presentation today. And again, I'm hoping that this will work. I'm calling for Jen Malachar from Cardiff. Jen, are you there?
I hope so. Can you hear me?
I can hear you. I can't see you yet, but I think the people of the techniques are working on it.
Fabulous. I've shared my screen. Hopefully they can see that. Is my screen shared? Or
We
is that...
don't see it yet, so I again call for the... Yes, I see you now.
Fabulous. You've got the whole screen and my face there.
Yeah.
Fabulous.
No, I can't see your screen yet. I can see your face, so what do you prefer? Now I see a double face and a screen.
Oh, fabulous. Okay, you can see me. Yes, I can see. Good.
Okay, you have 15, 20 minutes for your presentation, so looking forward to it.
Okay, thank you. So I've been very lucky in that it feels like I'm coming to this talk from the future about 2 or 3 years' time, because you've had all the slides showing success in the clinical trials and studies. I'm the person saying we've now got over 1,200 patients on depot buprenorphine in Wales. This is our actual clinical experience. Normally this happens 2, 3, 4 years after release, after those sort of studies, but we've been lucky because of the pandemic. We were funded by Wales to just give Buvidal, which is the version of long-acting injectable buprenorphine available in the UK at the moment, to pretty much everyone. And we have seen it as an amazing bridge to healing. I'd have loved to be there with you in person. I nearly got there, but my son tested positive for COVID because there's a lot going around in Bristol. So I'm here in Bristol, but nearly got to see you in Biarritz, hopefully next year. So I hope I'm presenting a very balanced view, because if you look at my consultancy work, I try to work with everyone in the field, and I continue to do so. And it's lovely, after 25 years prescribing methadone and then 20 years of prescribing buprenorphine, to have something new that really brings people to recovery. It really feels like all of them say, and I'll give you examples, but all of them say, you know, their daily opiate use is preventing withdrawal. It feels like they're drowning and coming up for air every day, and that's all they do with their lives. And then this Buvidal, the long-acting injectable buprenorphine, is like a buoyancy aid that just gets them to the surface. And over half of them just swim off and get on with their lives. And it's been a struggle, because we as services are used to them doing badly. You know, the best you can do is be on a treatment, or is your dual diagnosis worse? Are you still using crack cocaine? Are you still with social services? Have you gone to prison? Whereas how do we score? You are at work, you are doing well. So I'm going to show you an example and then give you some of the data that's just piling out with what we know. So first of all, here we go. Next slide. Okay, this is Amy. This is a very typical patient that we normally see in our clinics. She's on 100 pounds of heroin and 100 pounds of crack cocaine. She was injecting in her neck and her legs because she'd run out of sight. Her legs were full of infection. She was regularly in ITU with heart valve problems because of that. She was regularly in prison. She was homeless. She would tell me that she would finish her sex working at 3 a.m. and make sure she walked down to the docks, because there she could always buy a bag of heroin. She didn't care if she was raped or abused on the way. She would have that bag of heroin ready for her when she woke up in the morning, because she did not want to suffer the withdrawal. Her mother, who I also spoke to and got the Health Minister of Wales to talk to her as well, would say she would take Amy's photo round the homeless agencies and the police so that when she was found dead in the gutter, they would know she was loved. And then she had Buvidal, and the change was remarkable. This is Amy. She re-engaged within a week with her family and her 3 children. Her mother was looking after them. She started not 1 but 2 jobs. She totally stopped using any heroin or crack cocaine within that week. As you can see, she put on weight, returned to normal life. She found a fiancé in one of her jobs. They are now engaged. They chose to become pregnant now. She is now in her 3rd trimester. She was initially immediately referred to social services to have the baby taken away, but social services after 20 weeks said there is nothing to find. And we do not have the forms to say that. She is well, she is stable, she's in 1 job now, not 2, still paying her taxes. She's not been to prison, she is healthy. Another interesting thing, going back to Ikro's talk at the beginning, she had lots of dual diagnosis labels and nothing in the last 18 months since she's been on the Buvidal. She's come off the Buvidal successfully and detoxed. Again, the detoxification was trivial and easy. We've now got a decent cohort of patients who've become pregnant whilst on Buvidal and then had the babies, and following up Gabrielle Fisher's great work on buprenorphine, it's the same, it's as good. So that is Amy for us. I've called her Anne here as well. She was injecting, as you can see, I'm just checking I've covered everything. Yes, she's just moving on with her life. This is not the same person. This is why services and patients are so enthusiastic about it, and why here in Wales we've started using it and now have approximately 15% of our patient groups across Wales on it. So what makes us feel enthused? Well, here's some of our early data that we tried to classify that. Oh my word, isn't this amazing? We measured their clinical global inventory, which is an objective marker of how well they're doing. And right at the start, when you scored them before their first dose of Buvidal, it showed severe disease. At least they scored 5. It was, Amy would score a 6 probably there. And then within a week, the red arrow on the screen there, it dropped. They were much better. How do you quantify? A week ago, I saw somebody who was homeless and dirty and disheveled, and this week he's coming for his injection. He's wearing a hard hat, a safety vest. He's gone back to work on the building site because the foreman took one look at him and said, although I got rid of you 2 years ago because of your heroin use, you're fine. Come back to work. This is sustained. We've followed them up over 6 months with these measures. You can follow them up for longer. They're sustained. If you get past the first week, we have about 90–95% retention at a year. And we were lucky in Wales because we were given the opportunity to give it to everyone. So taking you through this busy slide, we've now got over 1,200 patients on Buvidal in Wales, but it was a slow start. So bottom left-hand corner, we've got the approval in late 2019. And within a month, the first non-NHS patient was on it, but there wasn't much funding. The non-NHS could move fast because they don't have many meetings. We then had the first NHS patient at my service about 4 months later. That's because I found there was not 1 committee, not 2 committees, not 3 committees, but 4 committees to work through. But then, luckily, the bureaucracy just stepped back because COVID came along. And COVID was fantastic here, bizarrely. You had the Welsh Government commissioners. We put a bid in saying, can we use Buvidal because we don't want people picking up at the pharmacies. And they said, yes, use it on everyone. And so we could just keep on going. We had the first prison patient a couple of months later with more and more use in prison. We finally, right at the end there, about 4 months ago, we finally had the first GP, the first primary care patient in the UK start on it. And as I say, we're just keeping going because everyone is working together on this. So what do I mean by that? Well, we've had the proactive commissioning. There were the successful bids locally and into Welsh Government. That proactive commissioning generated a great collaboration. We worked well together. We tried to move things on, and because of COVID, the bureaucracy stepped back, and instead of saying no, they said, please go ahead. So we could move at pace. The service had great flexibility. We could change things and move things on from the very methodical and correct procedures to allow the FDA and the EMEA to say this is a safe drug. We could change those quickly over the course of 3 to 4 weeks rather than the usual 3 to 4 years to move things on. So we had a look, and if you look at the steady state concentration, so this is some of Adrian and Nick Linzeris' summary work of the doses that people have found. You can look on the left, there's the steady state dose range for 16 milligrams of sublingual buprenorphine. And we had CAM 2038 or Buvidal, and we could immediately see that the 24 milligram weekly dose and the 96 milligram monthly dose roughly fitted with 16 milligrams. And 16 milligrams really is the right way forward for everything. So we looked and said, actually, we can pivot away from a small startup dose, some dosing over weeks. We were going, we need to move fast. We need to get these people out of our clinics because of COVID. And actually what we found was, it was great. There were no problems with that. We had an enthusiasm for changing. So we moved to, for example, what I've labeled there as 4-24-96, which translates as they had 4 milligrams of sublingual buprenorphine, or supralingual, I mean, whichever one was there in the clinic. 20 minutes later, they had the weekly dose of 24 milligrams of Sublocade, Buvidal, and then a week later, they had 96 milligrams of the monthly. We could adjust the doses. It was a pleasure seeing them, giving that dose. I would frequently come in, and even though I could get my juniors to do it, I still wanted to do it. So now I think I've given over 400 doses personally to over 100 patients, because you see them that first week when you give them the 24 milligram, you explain things, you say, I'm giving you a plaster on the site to reduce any infection because people scratch. So if everyone gets a plaster, the infection or redness just reduces. And then you see them a week later, and my word, these are new people, smiling, happy, turning up on time. The other option we've got there, 2-96, is in rural parts of Wales. We only see them once a month because the site is 100 kilometres from the main base. So they would have had 2 milligrams of buprenorphine orally the day before, 2 milligrams on the day, and then straight to a monthly 96 milligrams. Fabulous. The uptake there is just where I say 19 out of 19. 19 out of 19 of my nurses thought it was wonderful. They wanted to keep using it when we did a study of them. They said, this is just fantastic. And it's a revolution. I really have to say that. My receptionists like it. They come in on time. They smile. They ring if they're running late. This is unheard of in normal clinics. And just to add some early data around deaths, we now have some services where half of the patients are on Buvidal and half are on methadone. They're the people around prison release patient group. And we just did an assessment of the last 13 deaths to go to the coroner. So that's been across that time scale when it's been half Buvidal, half methadone. And all of them were methadone deaths. it's if you're on Buvidal, you really struggle to properly overdose and end your life, because it's a full opiate blocker. You can't have the opiates as the additional push for respiratory depression and death. Sorry, I've jumped a slide. Apologies. Another way of thinking about it is it's a bridge to recovery because of that. You've got your methadone and buprenorphine on the left in the land of dependence. The client is controlled by brain predisposition. We've all used buprenorphine as a fantastic detox agent. I developed a detox in a box thing with lefexidine in the past, which worked very well. You could do it in outpatients. That was great. People could climb over that molehill of detoxification, but that 4 to 7 year mountain of effort, it was easy to slide down and back because people had their plan A of medicine for stress and didn't have a plan B. Oh, apologies. What's lovely, I seem to have pressed the wrong slide, apologies there. What's lovely is you've now got this long-acting buprenorphine as a recovery bridge. It bridges over. People can stay in recovery and deal with their issues. Most people, because they have that buoyancy aid, they're no longer daily drowning, they just swim off. They go, I'm not spending all my time waking up going, how long till I run out? I'll just get on with it. Some need more work and some need a lot of work around their trauma, but they have the time and space and lack of anxiety to do that. So that's lovely to see. Moving on. So hopefully I've told you all of this. We needed to adapt. We needed to reduce the footfall. We started off thinking it's a reduction of footfall that we need to do, but we then found it was an amazing medication. And rather than me tell you, I'm going to use the words of some of my patients to say that. So these are, honestly, every time I give someone an injection and say, what would you say about Buvidal? They would say similar things. So I could trot out the same comments. Honestly, 15 out of 20 of my patients on Buvidal are remarkable recovery stories. Instead of on oral, you think of the 1 out of 20 that makes you come back to work every day because you remember they've done well. 15 out of 20 of these. Here we go. Methadone is just legalized heroin. The addiction is still running your life. A lot of addiction is just people, places, and things. Buvidal gives you the chance to get out of that environment into a totally different headspace. Another patient say you have less anxiety around going out. You're not worried about bumping into people who are actively using. You can't use heroin on top of it. Even if you wanted to get high, you can't. It's just amazing. I've had people describing trying to inject 2 grams of heroin on Buvidal and saying, I might as well have burnt my money. And another thing, it's liberating. Taking tablets every day becomes part of a routine. Like heroin, it is still every day. But with Buvidal, it feels medical. It takes away the addictive part. They're not craving. They're not waking up in the morning thinking, how long have I got? How long before I need to take my codeine, take my tramadol, take my methadone, inject my heroin? And this is the case across both the illicit opiates and, as I mentioned, the non-illicit opiates. We've got quite an emerging case series that this works well for anyone on daily opioids where there's a problem. Here's some data on that, looking at 142 patients, nearly 25,000 days of patient data. I think we'll publish one, we'll revisit this, and I think we've got 25,000 patient days of patient data. We were looking to see, is there a difference between the people starting and relatively stable on sublingual buprenorphine, as per all the previous studies you've just seen, versus those starting on methadone versus those starting on heroin. And actually, they all did remarkably well, remarkably well. If you look at these retention data, they look like the same smear, yet they're meant to be patients starting on buprenorphine, starting from heroin, starting from methadone. And in essence, once you get past that first 2 doses, it's 90 to 95% retention. And virtually all of them will have no heroin, no opiates in their urine screens after the first month. Some of them will continue to use other substances, but in general, at a reducing level or completely stop. So it's lovely to see that. It's lovely to see in the real world this works. And it works by giving it very simply, as I say. 1 weekly dose, straight to a monthly after that. No issues. Summary of the data, just to check I've told you. We've got over 1,000 patients now. Really, we're seeing remarkable reductions in their dual diagnosis as per the first patient. 80% have improved. It's more than that. It's closer to 90-95%. Just depend. We're just struggling to measure the numbers. 90 to 95% remain on treatment. It's got the same side effect if you move this. In fact, probably less side effects if you move to a weekly and then straight to a monthly, or straight to a monthly if you're in a rural place. And this shift of doing it that way is routine for us now. Now, a few other points to finish. What have we got emerging wise? Well, detoxification, certainly longer is better. So here, how bad is it? Heroin, the withdrawal severity is terrible. And within a day or two, people always know they seek that. So Anne, who goes and gets her bag of heroin at 4 a.m. to make sure she wakes up, that's because it's horrible. Methadone less so, but you need to be an inpatient. Buprenorphine less so, you can do it in outpatients. But if you time shift this away and look at monthly, honestly, long-acting injectable buprenorphine, it's going to put a lot of the inpatient units out of business. You have a detox at about 6 to 7 weeks afterwards. Some people don't even notice they've had any symptoms. We've stepped back and gone, we're telling you what's happening. We'll give you 4 days of well-being medications if you want, but quite a few people aren't even picking those up. So, what else is there? It's been a game-changing step change in some of the most entrenched. I mean, really, some of my nurses are going, can we put this person on Buvidal, Jan? Because they've been in and out of our service for the last 15 years. Let's try them. And they try them, and wow, a new person comes out because they suddenly stop that daily drowning and just float, and off they go. That stability, that going back on the top of the sea of life and swimming off, that's what many just needed for recovery. Although some want to deal with their underlying traumas, there's significant dissociation in this group, so it's very difficult to deal with them in like a PTSD clinic because they just run away from it. But my clinical psychologists love treating people with Buvidal because they go, these people don't have anxiety, they're focused, they want to move on. So we're evolving a tentative, tiered or stepped trauma-focused approach. About half don't need anything virtually, they just need their dose.
And 1 or 2 minutes.
Cool. Detoxification is the dog that didn't bark. Pain is another dog that didn't bark. And now why? Very quickly. Buprenorphine, it's unique. These are slides from Steve Husbands, who worked with or did his PhD with John Lewis, who invented buprenorphine with his team way back in the 70s. They needed to discover what buprenorphine, they needed a compound like morphine, and they discovered buprenorphine. There it is in the middle. It's a mu opioid partial agonist and a kappa antagonist. Bang. Because of that, you couldn't overdose on it pretty much. The blue line meant you could get a great response and higher doses plateaued, but therefore you could have that weekly or monthly. But with Buvidal or Sublocade, is it that we're seeing the kappa opioid antagonism? We're doing some research at the University of Bath looking at that. So allostasis is a way of getting activity over a long period, slow release. And is that finally giving you that kappa antagonism, which gives you that reduction in anxiety and prevents dysphoria? I hope it is. So in summary, it's well tolerated, massive change in lives. It's not that much more expensive once you factor in dispensing fees for the oral medication. I think it reduces offending behaviour and best service changes and what to use. We're still working on it and tweaking it, but we're tweaking it in the context of everyone wants to use Buvidal. It really stops the daily opioid despair. People have the energy to move into recovery. So almost you could say everyone on a daily opioid should try it because it could change their lives. hear it's changed somebody's life dramatically, but she's just one of many. Thank you.
Thank you, Dr. Medicare. So we have 20 minutes for discussion. Thank you first to all the speakers for this very interesting presentation. Buprenorphine is an effective treatment for opioid addiction. We all know that. But how can we optimize its effectiveness and limit its misuse? Maybe this innovation will help us and help patients. Do you have questions for the speakers? Yes.
Merci, Jean-Jacques Desglons. Je voulais témoigner de mon enthousiasme, enfin je dirais, je me retrouve 40 ans en arrière, lorsque nous avons été les premiers à utiliser la méthadone. Après des années d'échecs, de sevrage rapide, d'utilisation de n'importe quelle molécule, et brusquement, on tombe sur une molécule avec immédiatement des résultats assez fantastiques au début. Récupération rapide d'un travail, stabilisation de l'humeur et tout. Et je me retrouve dans cet enthousiasme des thérapeutes et des équipes 40 ans en arrière. C'est ce que je voulais dire. Et je pense qu'il y a pas mal d'avantages et d'avenir pour cette molécule. Et je comprends enfin l'envie de communiquer cet enthousiasme à tout le monde.
Thank you for this comment. Another question or comment?
Merci beaucoup pour vos présentations. En fait, donc moi je connais très mal, mais je saisis pas en quoi c'est, parce que ça a l'air d'être manifestement une révolution, mais je ne saisis pas en quoi c'est une révolution et en quoi ça constitue un grand apport par rapport à la buprénorphine classique. Donc j'aimerais bien des explications sur le plan pharmacologique, pourquoi il y a un tel engouement et pourquoi les patients, puisque vous, dans la première présentation, vous vous intéressiez en effet au retour des patients, donc ça a l'air quand même très apprécié. Sur quel... Qu'est-ce qui est si apprécié par les patients et qu'est-ce qui fait que vous décrivez une telle révolution? Merci.
Innovation or revolution? You can answer.
I can try to at least
take the microphone.
Hello, I can try to give at least some insight into that from our perspective. And I think, I mean, the idea of feeling normal, I think, is something very important here. And conceptually, it's the fact that you have a constant level makes and avoids these kind of dips and ups and downs during the day. And I think that has a profound effect. There is another more complicated matter which has not been addressed yet, and we don't really know if there is a difference, but if you give buprenorphine subcutaneously, basically you have 100% bioavailability and you have very little in terms of production of metabolites like norbuprenorphine and others. And that's why you can dose much lower doses with depot, if it is Sublocade or if it is Buvidal or whatever form. So you have much cleaner chemical profile here, which is important. But I think the profound thing, and maybe is something that Dr. Melliker talked about here before, is that this stabilization and being kind of not thinking about your next dose and not thinking about this repetitive behavior, that is probably a large impact.
You want to add something?
Yeah, no, I can echo I think buprenorphine has been available for a long time, and we've done lots of research in the clinic to understand where the therapy lies. So we now have products which can keep patients in the therapeutic dose range over the whole month. So you're not moving in and out of therapeutic doses. You can consistently keep that. But what that does is it controls a lot of the symptoms of the disease, but at the same time is giving you an opportunity with your other treatment approaches to start sort of deconditioning lots of learned behaviors, which the patients will need to sort of carry on with their lives. So I think you have two things working very well together with these long-acting options here.
Can I add something to this? Hello?
Yes, Adrian, yes?
Yes. So one more thing to add is if a patient is taking sublingual buprenorphine, any day they can choose to take it or not choose to take it. If they have depot buprenorphine, it's there. They can't remove it. It's there. So it's a different commitment to being in treatment.
Can I add as well?
Yes.
Yeah, I would say it started off, we all thought it was an evolution, you know, weekly, monthly, this is much better, again, for what Adrian just said. But it then becomes a revolution for reasons we don't quite understand, but you see these patients just get up and get going and move on with their lives, and you go, at last there is something that I can see helping these patients, and my receptionists see it, the nurses see it, their families see it, the patients see it. So there's something extra pharmacological. We don't quite know what it is, but it's such a profound, quick change. It's wonderful to see. I can guarantee if you give whether Buvidal or Sublocade to 2 or 3 patients, you will also be as enthusiastic as us.
Thank you. Next question. Yeah.
Moi, je travaille à Bruxelles et donc je suis généraliste et j'utilise beaucoup la méthadone bien plus que la buprenorphine. Et évidemment, je vois l'intérêt de ce produit, surtout chez des patients qui ne sont pas stabilisés avec la méthadone pour des raisons diverses. Je pense par exemple à un patient qui souffre de troubles neurologiques et qui n'arrive plus à prendre ses comprimés journaliers, et donc il se retrouve en manque parce qu'il a des problèmes de mémoire. Et d'autres cas de ce genre seraient très intéressants à passer à votre produit, mais évidemment je ne vois pas l'intérêt quand les patients sont stabilisés. Alors je ne sais pas si quelqu'un de l'ancienne ou la Nouvelle Galles peut me dire la réponse.
Do you have an answer for that?
Jen, can you say?
First line treatment?
Yes, I would say it's very much first line treatment now. We've moved certainly in some of our services to go try. In fact, no. With us, it's our patients are saying, I want Buvidal because I've seen my friend who's been using for 15 years and never came to services, try Buvidal, it's been amazing, can I have some? So it's moving to first line because patients are going, we want this.
So how do you move patients from methadone, if they're stable, to Buvidal or Sublocade?
That's quite easy, really. Basically, from oral buprenorphine, you just transfer straight over. From heroin, it's exactly the same as transferring to oral buprenorphine. Whatever way works, you know, just get them. We do in our clinic 4 milligrams of sublingual or supralingual buprenorphine, and 20 minutes to 30 minutes later, give them the injection, job done. From methadone, in Scotland, they reduce them down to 70 or 80 milligrams of methadone and then transfer. That's because they don't care, because it's quite uncomfortable for 2 or 3 days. But the Scots don't care. Let's move on. But we reduced down to between 30 and 50 milligrams of methadone. And then when you transfer from that dose, again, similarly to transferring to oral buprenorphine, people experience 1 or 2 days of discomfort, and then they say when they come back a week later, I have had 5 days of feeling brilliant, doctor, best I've ever felt. And this is why I keep working in the clinic. So it's easy.
Oui, bonjour, merci pour ces présentations. Je crois que c'est très clair d'un point de vue pharmacologique. D'un point de vue patient et au quotidien, on sait qu'il y a un certain nombre de patients qui ritualisent leur prise de traitements oraux et qui ont aussi toujours besoin de cette sensation de high, tout en étant très bien stabilisés sur un dosage au long terme. Comment vous gérez ça avec ce type de produit ?
Thank you. That's a very good question. I think the most important element is that choice for the patient continues, that the patient isn't forced to try buprenorphine or to make a change. It's the patient's choice, and they can choose, and that's very powerful. At my clinic, we have over 1,000 patients, and of all the patients on buprenorphine, more than half now are on buprenorphine, and that's not our clinicians telling them to do that. It's the patients asking for this because they talk to other patients and they said this is much better for you, much easier. So don't force patients to do something they don't want to do.
Oui, bonjour. Une question un peu dans la continuité de ce qui vient d'être posé. Donc déjà, je partage totalement l'enthousiasme que vous avez par rapport à la nouvelle forme et la prise en charge addictologique. Simplement, là, je revais un petit peu ma casquette de vigilante, puisque je travaille au centre d'addictovigilance de Paris. Et pour les usages, notamment, vous pouvez tout à fait avoir, nous, c'est ce qu'on observe dans nos enquêtes, des associations avec d'autres substances. Alors, je sais bien que d'un point de vue de sevrage, si jamais la personne reprend des opiacés, il y a un effet plafond qui est bien déterminé et prouvé pour la buprénorphine. En revanche, par exemple, si on voit le trafic de rue qu'il y a, par exemple, en Île-de-France, on sait qu'il y a des associations avec effectivement l'alcool, les benzodiazépines, la prégabaline qui n'ont pas du tout les mêmes mécanismes sur les mêmes récepteurs. Et pour la prégabaline, même si ça n'a pas forcément été démontré pour la buprénorphine elle-même, mais on sait que les usagers l'utilisent notamment pour potentialiser l'effet des opiacés. Donc là, je rejoins le commentaire de mon confrère juste avant qui parlait de l'effet shoot. Donc c'est quelque chose qu'on pourrait éventuellement supposer qui pourrait être utilisé. Et donc, ce que je me demande, c'est comment, dans ce cas-là, on gère des overdoses. Si jamais c'est avéré, je ne sais pas si vous avez pu observer ce type de cas ou pas, parce qu'on n'a pas le contrôle sur les usages en dehors du traitement que vous allez donner, surtout avec une forme LP, et sachant que la buprénorphine, en plus, ne répond pas de la même façon à l'analoxone qu'on peut avoir, que ce soit dans le kit intramusculaire ou intranasal. Donc, quelle est la conduite à tenir? Mais j'ai envie de vous dire, finalement, ça peut même être quelle est la conduite à tenir en cas d'une une erreur d'administration, parce que là, j'ai bien compris que le Buvidal est administré par le corps médical, mais même nous, on n'est pas infaillible, on peut se tromper et donner pas la bonne dose. Et dans ce cas-là, quelle est la conduite à tenir?
Not worry too much, because actually it's so safe, you can't get to overdose levels. It's this is a thing that's been troubling the buprenorphine field for 20 years, with people worrying about overdose and what you can give, and can you give naloxone, can you give naltrexone, what about pain relief? And as I alluded to, it's another dog that didn't bark. We've never had problems in hospital with admissions because people are on oral buprenorphine and cannot have their pain treated. And as Marc showed earlier, in several decades ago, the amount of people overdosing on buprenorphine is far smaller than those on methadone, and most likely, actually, that's buprenorphine in their system from several days ago. I can just reflect the last 13 people who died in our service were on methadone. We haven't had them on the long-acting. We're just not seeing that. We're not seeing those overdoses. My patients test the blockade initially and they say, I've wasted my money. It doesn't have any effect.
And can I just add, in terms of other drug use, so Frederick presented the data from the Australian study. So we didn't see any greater increase in use of benzodiazepines or stimulants or cannabis in the group on depo-buprenorphine compared to sublingual buprenorphine. Your question is a very good question. All of our clinicians were worried. The doctors, the nurses were worried. If you have depo, you only see a patient once a month. Is there going to be lots of other drug use? But we haven't seen it. It's not something we experience.
Thank you.
Oui, bonjour. Léon Gombehoff, Association Europe. J'avais une question qui était un peu peut-être philosophique, du fait que dans la... je pense que l'enthousiasme, ce qu'on a dit, la partie non pharmacologie de la chose est très importante, parce que je pense que pour prescrire de nouveaux médicaments aux patients, les équipes doivent être très enthousiastes. Mais après, ça joue sur la décision du patient. Et les patients, ils décident de façon diverse, donc même mélangeant avec d'autres drogues, par exemple, ou en voulant prendre même la même drogue qu'ils consommaient avant, l'héroïne, ou dans les cas que nous connaissons à Paris, l'esquénant. Et donc là, quand même avec un traitement de buprenorphine sublingual, il peut arrêter ce traitement et prendre l'héroïne ou l'esquénant. Et avec un traitement de libération prolongée comme celle que vous proposez, ça devient un peu plus compliqué. Donc je me dis, est-ce que ce ne sera pas un traitement aversif comme ceux qu'on connaît pour l'alcool, ça joue aussi sur la liberté du patient. Alors, c'est lui qui décide à chaque mois quand il va être injecté, mais dans cette décision, qu'est-ce qui joue? Est-ce qu'il y a peut-être... Parce qu'on sait quand même que la rétention dans les traitements avec la méthadone, c'est beaucoup plus fréquente et est meilleure qu'avec la buprenorphine. Mais quand vous... à chaque mois quand ils viennent et ils demandent avoir à nouveau ce traitement. Donc là, il y a une décision. Qu'est-ce qui se joue? Est-ce qu'il y a un type de personnalité particulier qui veut ne pas jouir de drogue? Je ne sais pas. Vous voyez, c'est une question un peu philosophique.
Merci. Patient profiles.
Give a very short answer. One, the patients choose to come back every month. For the methadone, they say, we don't come back because we want to, we come back because we're in withdrawal. Secondly, in terms of clinic staff, actually, it's really hard to get my clinic staff enthused about anything new. They are ultra conservative. And it took 6 to 9 months to get 19 out of 19 nurses enthused because they saw the actual results. So it's patient-led. The patients see it and see benefit, and they turn up for the appointments by choice. They're not in withdrawal. All of them are telling me, I'm here because it works for me and lets me get on with my life. I'll stop there.
Okay, let's stop here. We really have to stop. I think this has been a very interesting session. I've met various sessions where people were skeptic. And let's stay skeptic scientifically, but also let's stay enthusiastic for treating our patients. And there is new ways, and let's see next year or the next ATHS what the result is in Europe. We're still enthusiastic. I get very enthusiastic about it, and I hope, and I see that you're getting enthusiastic, I hope that these medications are on the market in Europe very quickly, and that we have another meeting in 2 years where we have more results and more experience. So thank you very much for joining this session.